All right, so let's finish up with renal. I wanted to touch on a couple things that I sort of skimmed over a little bit. One thing is, in terms of the distal convoluted tubule, you're going to see a lot of similarities in the distal convoluted tubule as well as the collecting ducts in terms of how it responds to different hormones. So it's going to respond to aldosterone to allow for absorption of sodium. That's going to happen at the distal convoluted tubule and in the collecting ducts. And then you're also going to see reaction to parathyroid hormone as well as calcitriol. So parathyroid hormone, you guys remember, that's supposed to be released when you want to increase the amount of calcium in your bloodstream, right? Because calcitonin basically reduces the amount of calcium. Parathyroid hormone, you want to increase the amount of calcium. And so what's going to happen at the distal convoluted tubule is that you're going to start getting reabsorption of calcium at the distal convoluted tubule. So you can increase your calcium levels. Calcitriol is another thing that comes into play. There's a cascade for calcitriol, but it's beyond the scope of this for 202. You guys went over it when you talked about integumentary system the previous semester. So vitamin D is going to be really important in this whole process of like increasing calcium levels. Vitamin D coming from the sun, right? And then there's like a bunch of different cascades with intermediaries. And then once you finally get to the kidneys are going to help to reabsorb calcium, right, with vitamin D. So that's going to be effectively what's happening. And that's going to be happening mostly at the distal convoluted tubule. You get a little bit of calcium reabsorption as well in the loop of Henle, but you're going to be seeing a lot of that at the distal convoluted tubules as well. And then antidiuretic hormone. You're going to see antidiuretic hormone having its effects in the distal convoluted tubule as well as the collecting ducts. And the main way that that's going to happen is through aquaporins. So aquaporins are going to be these little tiny pores that are going to be inserted into the apical membrane or apical region of those cells within these areas in the distal convoluted tubule and the collecting ducts. And so it's going to allow for reabsorption of water, right? Because if you're dehydrated and you're releasing antidiuretic hormone, you're going to want to try to minimize the amount of water that you're losing through urination. And so that's what's going to happen with antidiuretic hormone. Just remember, aquaporins are associated with that, and that's also going to be associated with reabsorbing water. So you're going to reduce your urine volume. All right, so here's the distal convoluted tubule, an image of what that looks like and some of the things that are taking place here. So with aldosterone, especially, with aldosterone, you're going to see reabsorption of sodium and then excretion of potassium. It's kind of, you're swapping one for the other, right? You're exchanging sodium for potassium. And so if you had a prolonged exposure to aldosterone, over time, you're going to lose a lot of potassium, and so you might start becoming hypokalemic as a consequence of too much aldosterone. Bringing in also a lot of sodium, so you'll be hypernatremic, you'd have a lot of sodium, and then remember, water follows solutes, so you'll be bringing on more water through osmosis. And so that's what's going on at the distal convoluted tubule. You have those sodium-potassium exchange pumps as a response to aldosterone secretion. All right, and then we went over the collecting ducts already, but let's kind of reiterate. Just remember the two hormones that are really important, aldosterone and antidiuretic hormone, both distal convoluted tubule and within the collecting ducts. Okay, so you're going to have aquaporins being inserted into all these cells along here so you can reabsorb water. And then I really like this image over here because it kind of shows you what's going on at each step of the way. So to begin with, you have filtration, right? So you're filtering urine out of the glomerulus. Then you have at the proximal convoluted tubule, you have a lot of reabsorption. The most reabsorption that happens is going to be at the proximal convoluted tubule. That's going to be water reabsorption. It's also going to be reabsorption of different ions like sodium, sodium chloride. Then when you start getting down into that descending loop of Henle, remember, descending loop of Henle is where you see water reabsorption. And then at the ascending loop of Henle, it's impermeable to water. So no water is going to be going through there at all. And then when you get towards closer to the distal convoluted tubule, that's when you start seeing sodium chloride being reabsorbed And then whether or not you have the presence of antidiuretic hormone and aldosterone, that's where you see both distal convoluted tubule and collecting ducts reabsorbing both sodium as well as water, and then also excreting potassium. Right? So aldosterone, reabsorption of sodium, excretion of potassium. And then this is where we closed last time. So these are some of those images talking about water reabsorption. If you don't have antidiuretic hormone, then you're going to be increasing your fluid volume because you're not reabsorbing water, so your urine volume is going to be greater. And then if you're not well hydrated, then you're going to be increasing the amount of water reabsorption due to the presence of antidiuretic hormone. Side note, antidiuretic hormone, another term for that is vasopressin. Okay, so antidiuretic hormone and vasopressin are both the same thing. And then aquaporins, that's what's going to be really important about antidiuretic hormone. Those aquaporins are going to be what get inserted into the apical membrane and then allows for water to come back in to the cells. And so this is where we wrapped up last time. So let's continue on. Any questions on any of those different regions of the nephron? Okay, awesome. So this is just a side note in terms of what diabetes means. We talked about diabetes already when we were discussing insulin and the pancreas, right? Remember, if the beta islet cells get wiped out, what is that, diabetes 1 or 2? Diabetes type 1 is where you have destruction of the beta islet cells that release insulin. Diabetes type 2 is going to be insulin resistance, right? So you're not going to be responding to insulin, and so blood sugar remains really high. Diabetes means to pass through. So in other words, if your blood sugar is really high, it's going to pass and exceed the renal threshold, so it's not going to get reabsorbed, and it's going to wind up getting excreted into the urine, right? So diabetes mellitus is the diabetes we already talked about when it comes to insulin, either no insulin release or insulin insensitivity. That means it's passing through the kidneys, and mellitus means sweet. That means you have sweet, sugary urine, right, because you're excreting more glucose. Diabetes insipidus is a little bit different. Diabetes insipidus has to do with fluids. So insipidus means zero taste. That means that if you tasted the person's urine, you wouldn't taste anything sweet. And guess what? Doctors back in the day, before things were kind of like sophisticated like we have nowadays, that's kind of how they used to diagnose diabetes in their patients. They would literally do a taste test of the patient's urine. And if it tasted sweet, they knew the person had diabetes. If it didn't taste like anything, then, they didn't have diabetes. So if you had a patient that was urinating a lot and they had polyuria, polydipsia, that means they have an issue with antidiuretic hormone. That means that everything is passing through at a higher volume, and it's going to be tasteless because there's no glucose. So that's going to be called diabetes insipidus. And there's a couple different types of diabetes insipidus. The two most common are going to be central diabetes insipidus and nephrogenic diabetes insipidus. These are going to have to do with antidiuretic hormone. So if you remember what antidiuretic hormone does, or vasopressin, that's the other name for antidiuretic hormone. Antidiuretic hormone prevents diuresis, right? It's inserting those aquaporins into the distal convoluted tubule as well as the collecting ducts, and so you're allowing for reabsorption of water. If you don't have antidiuretic hormone, you're not going to be reabsorbing water, and so you're going to be urinating at a very high frequency. It's a lot of urine production per day, so it's kind of crazy. It's very you would imagine how uncomfortable that would be for the patient. Central diabetes insipidus is going to be associated with the pituitary gland or the hypothalamus, because remember, the vasopressin, aka antidiuretic hormone, produced in the hypothalamus, stored in the posterior pituitary, gets released, right? And then, so that's going to be central. That means central nervous system. And then the nephrogenic is going to be at the levels of the kidneys. They're not going to be able to respond to antidiuretic hormone, aka vasopressin. So those are the two major kinds of diabetes insipidus. With those types of patients, they are going to be peeing a lot. Okay, so they have a really high urine volume. Because they're losing so much fluid, they're also going to be extremely thirsty. So they're going to be drinking a lot of water. So they call that polydipsia. Okay, so polyuria, frequent urination, high volume. Polydipsia, frequent drinking of water to try to make up for all the fluid loss. There's other types of diabetes insipidus. There's gestational diabetes insipidus. Has to do with the placenta is going to be releasing an enzyme that breaks down antidiuretic hormone. And then there's also primary polydipsia, which it's a little bit different. This is a person who's really, really, really thirsty. And so because they're really thirsty, they're also going to be producing lots of urine as a consequence. That could be due to, defaults in their thirst regions, maybe of like the thalamus. That's going to be where you have like thirst signals being sent out when you want to drink. So that's going to be a little bit different. But these are going to be the two most common kinds, central and nephrogenic. And these are really good summaries of everything that we talked about over here. So you start with the glomerulus, where you have filtration taking place. From the glomerulus, you get the proximal convoluted tubules. You have lots of reabsorption of water, electrolytes, etc. And then note the osmolarity of the urine or the filtrate. The osmolarity is going to start at a low osmolarity. That means it's pretty diluted, right? So not as many electrolytes and other things that are in the urine. As it moves down the descending limb of the loop of Henle, note the osmolarity starts to progressively increase. That's because now you have water being reabsorbed from that loop of Henle, and then you're left behind with a filtrate that is going to be much more concentrated, that has a much higher osmolarity. Then, as you start moving up the ascending limb of the loop of Henle, then you start getting electrolytes are starting to be reabsorbed. And because you're reabsorbing electrolytes, now you're leaving behind more water. And so again, you're going to start winding up with a more dilute urine, right? So you're removing those electrolytes, sodium, potassium, calcium, etc. Note no water movement here at the ascending limb, just the movement of sodium chloride. You can also have calcium as well if you have the release of PTH, right, parathyroid hormone. Then when you get to the distal convoluted tubule, note sodium, potassium being exchanged for one another. That's going to be due to the presence of which hormone? Aldosterone. Good, aldosterone. Aldosterone taking place at both the distal convoluted tubule and at the collecting duct. And so that's going to be due to aldosterone, and then aquaporins, the movement of water, that's going to be due to ADH, vasopressin. And here's another image. This, don't bog yourself down with all the details here. You don't need to know every single electrolyte, every single ion that's going to be reabsorbed or excreted. Just know the major ones. Know sodium, know sodium chloride, know where if you have the sodium-potassium exchange pump, know that potassium is also going to be excreted at, like, for instance, distal convoluted tubule, collecting ducts. And then I highlighted this region right here is because it kind of stresses what's going on with ADH as well as aldosterone specifically. That's going to be involving the distal convoluted tubule and the collecting duct. So that's going to be really important for you guys to remember. So what's going on with the kidneys? The purpose of the kidneys effectively is to be able to maintain homeostasis. It's also going to be responsible for like fluid balance, also responsible for excreting toxins and wastes, things that start accumulating in the body, for instance, from like amino acid breakdown, stuff like that. And so you're going to be able to remove a lot of different metabolic wastes. Also drugs, if you remember from last time, drugs are also going to be excreted from the kidneys, so you can remove chemicals as well. And then in terms of waste products, know that whenever you have like amino acid breakdown, or if you have other waste products from aerobic respiration, metabolism, that's all going to be dissolved within the blood until it gets to the urine. Once it gets to the urine, those wastes now can get filtered out through the glomerulus and then can get excreted through the urine. So these are the different things that are going to be like important waste products to be removed by the kidney. One of the major ones is going to be urea. So urea, that's where urine gets its name, right? Urea is going to be associated with the products of amino acid breakdown. Okay, so whenever your amino acids get broken down, you get urea accumulates, and that's what gets filtered out at the kidney. You also have creatinine, which is going to be excreted, and creatinine is going to be associated with respiration. So whenever you have respiration, then you're going to have creatinine. Creatinine, when you guys get into your clinics and you're going to see if your patient's kidneys are functioning well, creatinine is actually one of the things that gets measured from your patient's labs so that you can actually see if they have decent urine function. So this video, it doesn't go into too much detail, but it kind of gives you a decent idea of what's going on.
Most people have two kidneys, about the size of their fist, located in their lower back. Just like your brain or heart, kidneys keep you alive. Many people know their cholesterol and blood pressure, but they also need to know their kidney numbers to see if their kidneys are healthy or if they have chronic kidney disease, also called CKD. Having CKD means that you've had a kidney problem for at least 3 months. Chronic kidney disease can creep up on you slowly and silently, losing kidney function for many years without symptoms. Many people find out that they have CKD only when their kidneys have failed and it's too late for preventive. At this point, they usually need dialysis or a kidney transplant. That's why knowing your kidney numbers is so important. There are two kidney numbers: estimated glomerular filtration rate, GFR, measured by a blood test, and urine albumin to creatinine ratio, UCR, measured by a urine test. GFR shows how well your kidneys clean your blood, and the UCR shows if there's a protein called albumin in your urine, which may mean that your kidneys are clean. Along with your kidney numbers, your doctor reviews your health history and performs other tests. This complete evaluation helps to confirm or rule out if you have chronic kidney. Kidney numbers and different colors create the CKD, which shows you the possible risk of your CKD getting worse and your risk for heart disease. Good news is that when it's found early and treated right, the outlook for kidney disease patients is very bright.
All right, so doesn't really go into too much detail, but that's effectively all I really need to know for the sake of this class. So the urine creatinine versus albumin levels, that's going to be important to determine whether or not the kidney is doing what it needs to be doing. So albumin should not have in your urine, right? Because proteins shouldn't be in your urine. That would indicate renal damage. And then creatinine would help to measure how much filtration is taking place. So it's a good estimate of what's going on in terms of GFR, right? Glomerular filtration rate. Another one that's important is going to be uric acid. Uric acid is going to be a breakdown of anything that has RNA in it, and then you get an increase in your purines, right? So remember, RNA, DNA, it's going to be made up of purines and pyrimidines, right? Purines, adenine, guanine, right? A and G, those are going to be your purines. So if you have purine accumulation, you could eventually get gout. And this is what's going on with gout. You get uric acid accumulation, and they start depositing in different regions. Some of the most common places for them to get deposited is your big toe, right? So that's what's going on with this guy over here. The reason why this is kind of an interesting illustration is because back in the day, gout used to be associated with the royalty, right? These are people that would have lots of beef in their diet, lots of fish, drink lots of red wine. So proteins and alcohol consumption are going to be associated with gout. I had a patient once that had really bad gout. I asked him about his drinking, and he drank a lot of booze. And I told him, by the way, that's like a risk factor for gout. He's like, "Oh, really?" I'm like, "Yeah, I'm sorry, dude." But so for those of you who drink a lot like me, this might be something that you have to deal with in the future. So it doesn't just deposit in your feet or your toes. You can also get gouty. They call these gouty tophi. Gouty tophi can accumulate in other places too, like in the hands, for instance. You can only imagine how freaking painful that must be. So pretty scary. Here's a fun video that my colleague Dr. Jackson showed me yesterday. It was kind of hilarious, so I decided to include it in here.
What's the matter? Those diamonds in his shoes? No, I suffer from gout. Gout. A disease of kings, you know. Successful kings. A pop disease of little body is a sign of really married in modern society. Yeah, I suppose you haven't got gout. Get it? Not like gout. Get out. Call me when you've got gout. Does he forget that?
Anyways, that was kind of funny and relevant. So, anyways, speaking of urine concentration, so you can tell if urine is really, really concentrated just by looking at it. If a patient has super, super dark yellow urine, that probably means that the person is not drinking enough water. If they have really light colored urine, it kind of looks like water. That means that they're really, really well hydrated. So the one thing to keep in mind, though, is that if you take vitamins, like vitamin B complex, for example, those types of vitamins can actually change your urine color too. So you can get like freaking like neon yellow urine if you're taking vitamin B complex. So just keep that in mind when it comes to looking at the color. And then in terms of the concentration of urine, the concentration of urine is going to be quite a bit more concentrated than the plasma. So remember with plasma is made mostly of water, right? So you got proteins in there too, like albumin, you got immunoglobulins and things like that. But urine in general is going to be much more concentrated than plasma. So that's one thing to keep in mind. And if it's red, I don't know what's going on with this one. This might be hematuria. So sometimes if it's red colored, that probably indicates that there's blood in the urine. You can test for that using a urine analysis strip. Usually that means that the person had like an acute renal injury. So they might be a boxer. They might have got hit in the back or something in their flanks. That can result in hematuria. Usually it self-resolves. I even have like a student of mine who, he used to be a wrestler or a boxer or something. He actually had a acute renal damage. He was peeing blood for like 3 days and then it self-resolved. So it's not the end of the world if you have hematuria, but it's also not great. So let's talk about what's going on in terms of reabsorption and secretion. So we're going to talk about how much of a substance can be reabsorbed, and we're going to talk about the renal threshold and all of that. But first, let's talk about some basic terminology. So diffusion versus osmosis, versus channel-mediated diffusion, and carrier-mediated transport. So let's go into each of these. With facilitated diffusion, you don't really need any sort of energy input. It's just going to go downstream. It's going to go from high concentration down to low concentration. Active transport, where you're going from low concentration to high concentration, that's going to require energy input through ATP. You can have co-transporters. So remember the sodium-potassium co-transport. So you're exchanging one thing for the other thing, right? So that would be a good example, sodium-potassium co-transport. And then you can also have counter-transport. Actually, counter-transport is more like the sodium-potassium one, where you're actually exchanging one thing for the other, so it's going two different ways. Whereas co-transport, it's basically going two different things going in one direction. And then co-transport is also referred to as symport, and counter-transport is also referred to as antiport. So let's talk about these transport proteins that are going to be found within the kidney. So here's your blood vessel right here, and this would be the lumen of your tubule. So it's either your proximal or distal convoluted tubule or somewhere on the loop of Henle or even the collecting duct. So let's talk about what's going on here. So if you have some sort of substance, it basically binds to the protein transporter, and then it eventually winds its way into the blood. So that's what's going on over there. So let's talk about transport maximum. That means where you have full entire saturation of all those transport proteins. So if those carrier proteins are fully saturated, then the transport maximum will be met. But if you reach that transport maximum, that means you can still be able to bring things back into the blood. So you can still technically reabsorb those different solutes and substances. Now, if you hit the renal threshold, if you go beyond the renal threshold, that's when stuff starts winding up excreted in the urine. Okay, so you're not able to actually fully reabsorb those compounds. on the animation. So this is what, so you exceeded the renal threshold. Now anything extra beyond the saturated carrier proteins, anything that's extra now starts getting excreted into the urine. Okay, so that would be the renal threshold. So let's talk about the practical applications of that. We talked about diabetes, right? Diabetes mellitus means you have sweet tasting urine. It's kind of gross. But so if you have diabetes mellitus, that means you have way too much glucose in your bloodstream. That means that glucose is going to exceed the renal threshold. And when it exceeds the renal threshold, you're going to find glucose in the urine. So you can test diabetes just using a urine analysis strip, which I'll show you in a second. So you can use that to see how much glucose is in the urine. We call that glucoseuria. Okay? So if a patient has glucoseuria, that means they have glucose in the urine. Now, if they have too many amino acids, they might have eaten a lot of proteins. They might actually get amino acids in the urine, so that would be called amino acid uria. If the person has other proteins that don't belong in the urine, like albumin, we would call that proteinuria. Okay? So that's all involving the transport maximum and the renal threshold. So as soon as you exceed the renal threshold, which is this line over here, the moment you exceed that, now you're going to start detecting those substances within the urine, right? At this point, you're not seeing anything in the urine regarding those substances, right? Because they're able to get reabsorbed. Once you go beyond that renal threshold, then you start getting it into your urine. So here's glucoseuria. So this would be a healthy individual that doesn't have diabetes up here on the left. You don't have like total saturation of all those membrane proteins, right? So you're able to, or those carrier proteins, so you're able to actually reabsorb glucose. Because remember, it's not uncommon for you to get a little bit of glucose filtered in your urine, but you ideally should be able to fully reabsorb all that glucose. You're not supposed to have glucose in your urine. Now, a person with diabetes mellitus, obviously they have way too much glucose. That glucose is not going to fully get reabsorbed because it's starting to exceed that transport, the saturation of those transport proteins, carrier proteins. And so you're eventually going to find a lot of glucose in that patient's urine. Cool. Any questions? There's a question. I'm sorry, I didn't catch that. Oh gosh, because alcohol, first of all, you're drinking a lot of volume, depending on how much you're drinking. Right? So if you're drinking like beer, for example, and it's like something like Bud Light and it's basically water, then you're going to be increasing your overall fluid volume, right? So you're going to be increasing the amount of urine just as a consequence of the fluid volume. Alcohol also disrupts ADH, right? So alcohol does interfere with antidiuretic hormone, and because you're not able to release ADH properly and then get those aquaporins in those apical membranes of the cells, then you're not going to be reabsorbing water. You're going to be excreting more water. So you're going to increase the fluid volume because of that as well. So two things, overall fluid volume is going to be increased. Also, the alcohol does affect antidiuretic hormone. Good question, though. Oh, man. Anxiety medications. You mean like benzodiazepines, like Valium, Xanax, drugs like that? I don't know what effect those have on urination. Do they increase? She urinates a lot? She has increased urine frequency. I would imagine that benzodiazepines probably do have an effect on antidiuretic hormone, but I can't say for sure. I don't know exactly why. I know lots of meds, for instance, like stimulants. Stimulants can result in increased urination as well. So I don't know. I would have to look into that. So I don't know if I answered that question very well. I'll look into it. Speaking of a question that another student was asking about parasympathetic activation versus sympathetic activation of the kidney. The kidney does not respond to parasympathetic activation. It only responds to sympathetic activation. I think you asked that question the other day, and I forgot to get that back to you. So that's a total side note. I'm not testing you on that. Just know that sympathetic activation can change like vasodilation of the afferent and efferent arterioles. So let's talk a little bit about the urinary tract and what's going on here. Definitely, it's basic anatomy. You really should know all this stuff. But when you have the kidneys are eventually going to turn into wind into the renal pelvis, which eventually leads into the ureters. The ureters are the tubes that bring urine down to the bladder. Bladder is where urine gets stored, and then after the bladder, urine gets released through the urethra. Now, in terms of the ureters are interesting. Remember, I gave you guys that question a while ago about smooth muscle contractions and peristalsis. So you get peristalsis in the ureters. So that's kind of an interesting thing that you guys definitely should know. So you'll get peristalsis in the ureters that help to propel urine down towards the bladder. Something else that's interesting about the ureters is that they have slit-like openings, and because of that, it prevents reflux. It prevents urine from going back towards the kidneys as the micturition reflex is taking place. As the detrusor muscle, which is the muscle around the bladder, as it contracts, you want the urine to go out the urethra, not back up the ureters. And so because of the slit-like shape of the ureters, you're going to prevent regurgitation of urine, preventing backflow. Now, in terms of peristaltic contractions, they're going to happen every 30 seconds. One thing that to keep in mind is if you have a kidney stone, which is nephrolithiasis, if you have a kidney stone that gets lodged in the ureter, then the peristaltic contractions are going to try to push that urine further down. And then it's going to help move the kidney stone further, but it's going to also start creating a little bit of like reflux of urine back up the kidney. So it can definitely cause some discomfort in the kidney, not to mention pain and discomfort along the ureter as well. So not a very fun thing. I've had friends that have had nephrolithiasis in the past, and they told me it's like in terms of like 1 out of 10 pain, it's like 10 out of 10. Has anybody in here ever had a kidney stone before? What was it like? Was it excruciating? You're throwing up? Did they give you pain meds? Oh my God, that's awful. And somebody else had a kidney stone? Somebody else had a kidney stone up there? Yeah, well, pain. Did it really? Because the kidney stone caused damage as it was. Did they do the lithotripsy, which is like ultrasound, where they can like send ultrasound signals to break down the stone? Oh, okay. Huh. Interesting. Because they can do like lithotripsy, which will break the stone down. So this is an image of staghorn kidneys. Kidney stones, you can see they're staghorn because they're shaped like stag horns, like antlers. And so very, very, very massive kidney stones that oftentimes require surgical intervention to remove because you can't pass a staghorn kidney. Some people will try to do like radio, like the ultrasound frequency, radio lithotripsy, but it's not really effective. Let's watch a little video of a cystoscope. This is kind of interesting.
Hi, this is a case of simple diagnostic cystoscopy in the male patient. The male urethra is S-shaped. You should enter always under vision. And initially the black hole has to be seen and then you have to turn it up. The penis should be kept at 45-degree angle. And here this is a prosthetic part of the urethra. You can see here the volumentum. And either side the prostate is normal in the patient. And then you can enter into the bladder. This is the bladder. You will go to the posterior wall of the bladder and just at the place of tricon you can see the crease of the ureter. And here is the ureteric opening in the bladder. This is right side. This is posterior wall of the bladder, which is quite normal. And now this is the left side of the ureteric opening. The cystoscopy is important to diagnose many of the bladder pathology, as well as it can be used for putting the DJ stent or the UIS or the Ray's procedure. This is again the right side of the ureteric opening. You can see the crease of the ureter. Sometimes peristalsis also can be observed. This is fundus. Here is the left wall and this is the ureteric opening of the left side. This is a normal
All right,
diagnosis.
that became super anticlimactic very quick. So kind of cool. So that's a cystoscope. So you can like put in a scope so you can look inside the bladder. So very interesting stuff. So this would be a image of staghorn kidney stones right there. Just absolutely freaking massive. So they take up basically like all the minor calyces, major calyces into the renal pelvis. So brutal. And then now, not to compound the problem, you have like a little staghorn stone getting dislodged, winding up into the ureter. So this is urine actually passing through the right side. On the left side, you see there's no urine passing through because it's completely occluded. So not a good situation. In terms of kidney stones, the most popular of them all are going to be the calcium oxalate stones. So those are the most common of all of your kidney stones. Thank God those staghorn kidney stones are not as common, and those are going to be associated with urinary tract infections. So the organism that's usually responsible for this is Proteus mirabilis. It's a gram-negative GI bacteria that if it gets into the urethra, it can result in staghorn kidney formation or kidney stones. So really, really large and painful. Also, uric acid stones. Those are going to be one that's associated with gout. Remember we talked about uric acid accumulation, uric acid crystals, gouty tophi. So people with gout can sometimes get uric acid stones as well. Cystine stones would be associated with a type of genetic disorder. Homocystinuria is what would result in the cystine stone formation. Xanthine stones are also associated with a different type of like enzyme deficiency. You don't need to know that for this class, but silica stones are pretty rare and are associated with different types of medications and drugs, including herbal supplements. So the big thing to keep in mind about kidney stones, very, very painful. When they start, it starts kind of in the lumbar region, in the flanks, and then it starts slowly migrating down. As the kidney stone moves through the ureter, you can just feel it move all the way down. It's a very excruciating process. So you have to give them pain meds to be able to control the pain. And sometimes, if it's a really large stone, it might require surgical intervention. There's this medical text that I was reading that talked about like old classic procedures. There was this guy, this duke of some sort. I think he had a uric acid stone because he massive kidney stone, and he wanted to get it removed, but it was like back in those days, you had to do surgery, and to do the surgical procedure, you have to go into the perineum and without anesthesia. And so the doctor that finally did the surgery on this guy, because it became completely unbearable, this like duke dude wasn't able to tolerate the pain anymore. So he actually went in without anesthesia, went in, removed the stone, and the doctor kept the giant kidney stone as a paperweight that he kept on his desk for the rest of his life. So it was kind of an interesting story. And thank God we have anesthesia nowadays, because that would not be a very fun thing to experience. So anyways, this is the urinary bladder. It's going to have several smooth muscle layers that are going to be important for constriction, right? So those are going to be all part of the detrusor muscles. And then you have at the pelvic floor, so at the pelvic floor, you're going to have the external urethral sphincter, right? So that's going to be skeletal muscle, so that's voluntary. And above that, you're going to have the internal urethral sphincter. That's smooth muscle. That's going to be involuntary. So in other words, when you are able to hold your urine, that's going to be all done through the external urethral sphincter, which is skeletal muscle. In terms of what the bladder does, it's just basically a storage organ. It's going to effectively allow storage of urine. It can accommodate 1 liter, which is pretty huge. I'd like to go back to my wine bottle reference. Wine bottle, 750 milliliter, 1 liter. That's a little bit more than a wine bottle. So that's a lot of urine. Within the mucosa, you're going to see these little folds. Like this is all going to be rugae. Once the bladder expands fully, those rugae basically disappear. So if you remember from that cystoscope video I showed you, you didn't see any of the rugae because the bladder was completely inflated with fluid. So if it's completely emptied out, then you would see more prominent rugae. Then the muscularis muscle, that's going to be the detrusor muscles. And those are all going to be smooth muscles, aka those are all going to be involuntary type muscles. You have a couple layers. You have the layers on the outside and the inside. On the outside layers, you're going to find longitudinal smooth muscle and then circular muscles in the middle layer. And then the trigone, that's going to be that little triangular region that leads into the urethra. So it functions kind of as like a funnel. Now, there's going to be a difference between males and females, right? So males are generally going to have a longer urethra. Females are going to be shorter. For guys, it's roughly about 8 inches long. For ladies, it's going to be much shorter, so it's going to be 1 inch long. And the reason why that's medically important is because UTIs, right? Urinary tract infections are going to be much more common in women than guys. Guys can obviously still get them, but it's much more common in women. And it's literally just due to the short length of the urethra. So it's all based on the physical anatomy of the urinary system. But in terms of the muscles that are involved, so remember, internal urethral sphincter, smooth muscle, involuntary. External urethral sphincter is skeletal muscle, so it is going to be voluntary. So you can obviously control urination. We're going to talk about when that can go awry. There's a couple different conditions that can result in incontinence, but we'll talk about that in a second. So in terms of location, for females, it's going to be along the vagina. For males, it's going to be a little bit different. There's going to be a prostate. Right? When we get into sexual reproduction, we'll go more into the anatomy of these different areas, but the prostate is going to be in between the penis as well as the bladder, and we'll talk about the function of the prostate later. For females, the urethra is only going to be carrying urine. For guys, it's both urine as well as semen. So we'll talk more about that later on next week. Now, in terms of UTIs, lots of different bacteria can cause UTIs. Okay, so you can get UTIs from Pseudomonas. You can get UTIs from a Serratia, so Serratia marcescens. But the most common one is going to be E. coli. Now, a lot of these UTI organisms are going to be found in the GI tract. You can also get ones that are like found outside, like Staphylococcus epidermidis that you find on your skin, can also cause UTIs too. But by and large, a lot of the UTI organisms are going to be gram-negative organisms that are found in your gut, in your GI tract. One of the reasons why you get GI involvement in the urinary tract infections is because of just the proximity of the anus to the urethra for women. So it's going to be much closer, so it lends itself to getting more urinary tract infections in women. If the urinary tract infection moves beyond the bladder, so if it gets to the bladder, it's going to be called cystitis, right? And then if it gets up to the level of the kidneys, because you can get where the infection rises up. So if you get the infection rising up to the level of the kidneys, that can result in pyelonephritis as well as glomerulonephritis. Okay, so glomerulonephritis is specifically going to affect the glomerulus. We're going to talk about glomerulonephritis in a second here. So for women, shorter urethra, close to the anus. One thing that's really recommended, especially for women, is after intercourse to use the restroom, right, to flush out any bacteria that might have come into contact with the urethra. So that can help to reduce the chances of getting UTIs. In terms of signs and symptoms of UTIs, urgency and frequency is going to be a very common sign and symptom. Dysuria just means pain upon urination. Okay, so those are going to be two of the major symptoms. Just because it's infectious, right? It's bacterial. You might see fever. You might also see hematuria, which is blood in the urine, and altered mental status. Now, for those of you who might be working in the future with like elderly patients, maybe you're working in a group home, maybe you're working in a retirement facility. If you're working with elderly patients and all of a sudden your elderly patient starts acting all goofy, right? Starts having altered mental status, they start becoming delirious. One of the things you really should try to rule out first is urinary tract infection, because urinary tract infections, especially for elderly who maybe don't speak, maybe they're wearing diapers, right? So you get like defecation and all that bacteria can start causing UTIs. Altered mental status is usually a dead giveaway that the patient might have a UTI. They might also be having a stroke too. So you want to rule out other neurological conditions as well, but definitely also consider UTI as being one of the differential diagnoses. To diagnose UTI, you can do CNS testing. CNS testing means culture and sensitivity testing. When you do CNS testing, you culture the organism, and then you see what kind of antibiotics could be used against that bacteria. So that's what the sensitivity testing is. Because a lot of bacteria are resistant against antibiotics. You want to see which antibiotic would be a good, suitable option to treat that UTI. You can also see UTI in urine analysis, which I'll show you in a second. In terms of antibiotics, there's lots of different antibiotics you could use. A very commonly used one is going to be Bactrim, which is sulfamethoxazole, trimethoprim sulfamethoxazole. So that's a very commonly used drug. This drug in particular, the way it works is that it prevents the bacteria from growing, right? So it prevents them from dividing. It's a bacteriostatic drug. And so when they're taking this drug, it's not killing the bacteria, it's preventing them from multiplying. And so basically you're depending on the patient to be able to pee out the bacteria effectively. So they're going to be urinating, removing the bacteria through mechanical means. Glomerulonephritis. So glomerulonephritis can be caused by a couple of different things, but oftentimes it's going to be antibody antigen mediated. So you can get, for instance, post-streptococcal glomerulonephritis. That is a severe side effect of getting a really bad case of strep throat. So if it becomes systemic, you might get these antibodies that start getting lodged into the glomerulus, causing blockage, disrupting GFR, right? So your glomerular filtration rate goes down. So yeah, that's one of the big things with glomerulonephritis. This is what it would look like if you took a light microscope histological cross-section. Generally speaking, you should be, Generally speaking, you should be able to see the capsular space. If a patient has glomerulonephritis, that capsular space is going to be vastly reduced. That's going to be due to a lot of inflammation, as well as the inability for filtrate to be filtered out into the capsular space. So other things that can happen with glomerulonephritis, you might see high blood pressure. High blood pressure is going to be associated with inability to remove fluids from your body. It's going to cause fluid accumulation, which is going to result in high blood pressure. You might also see decreased GFR, decreased urine output, and you're also going to see changes in skin. You'll see skin pigmentation. You could see pallor, which I didn't include on here. Pallor, which is paleness, because of the kidney is going to be associated with the production of like erythrocytes. Remember erythropoietin? That's going to be released by the mesangial cells in the kidneys. So if you can't produce red blood cells, you're going to start looking pale, right? Because you're going to be anemic. But you can also get the accumulation of different compounds like urochrome, carotenoid. Don't worry about these compounds specifically. Just know skin coloration changes. But you can get yellowing skin. You can also get browning of your skin too due to melanocyte activation. And in order to treat this, you give the patient anti-inflammatories like corticosteroids. You might want to give blood pressure medication so you can reduce their blood pressure. ACE inhibitors are also going to be a good option for these types of conditions as well. And we already talked about what ACE inhibitors do. What does it prevent the formation of? Angiotensin 2, right? So it prevents the formation of angiotensin 2. So in other words, you would allow for vasodilation, you would prevent aldosterone release, etc. So this is what you would do for urine analysis. For one of my labs, we actually do this with we have a bunch of fake urine, and I usually volunteer one of my students to go to the restroom and do a urine analysis on their own urine, so you can see how this process is done. When you guys are out in the field in the future working with your patients, you're going to be doing this all the time. So what you do is you dip the urine into, you dip the stick into the urine, and then you're basically just looking for color changes. You're going to have on the bottle itself, it's going to have all the normal colors of each of those little tiny squares. You're going to see what normal looks like, and if it's abnormal, then you're going to be able to see what the values are, right? So you're going to be able to see what the abnormal values are. One example is glucose. If you get really dark readings on your glucose, you might have glucoseuria, right, associated with diabetes. It can go all the way up to like 2,000, which is really, really high. Other things that you can see, this is a good breakdown. Leukocyte esterase, that means you have a UTI, Okay, leukocyte esterates would be elevated in UTIs. Same thing with nitrites. Urobilinogen as well as bilirubin might be associated with some sort of liver damage. Proteins, you should not see proteins in your urine, but if you do, that's going to be proteinuria, indicative of kidney disease. pH changes could also indicate kidney disease. You might be able to detect blood if there's hematuria. Specific gravity. Specific gravity would be elevated if you have way more solutes in the urine. If the urine is really concentrated, then the specific gravity goes up. So it'd be like about 1.03 is a really high specific gravity. Water has a specific gravity of 1. If it's above 1, that means there's solutes in the urine. If it's really high, it probably just means the person's dehydrated. They probably just need to drink more water. If it's really low, that means the urine is very dilute, and so they're probably really well hydrated. Ketones. Remember with diabetes type 1, you get an elevation of ketones. So a patient with diabetes 1 might get diabetic ketoacidosis. You would be able to detect this using a urine analysis test strip. And then glucose, we already talked about that with diabetes mellitus. So let's talk about the actual act of urination. So the term that we use is micturition. Okay, so we would call it the micturition reflex. Okay, so micturition reflex is just a fancy word for going pee. It's going to be associated with stretch receptors in the bladder. That's going to be the first thing that happens. Once there's a certain amount of fluid within the bladder gets stretched out. Those stretch receptors now start sending signals to begin and initiate the micturition reflex. And so those are going to be involving afferent fibers. Afferent, those are the ones that are sending out from the bladder to begin the cascade. Then the efferent fibers are going to be associated with the nerves that are going to innervate, like the detrusor muscle, to allow for contraction of the detrusors to allow for micturition to take place. Bless you. Know that the major thing that's going on with the voluntary versus involuntary control is that the external sphincter, just remember that's skeletal muscle, voluntary. Internal sphincter is going to be smooth muscle, involuntary. Okay, that's going to be the major thing to keep in mind about the micturition reflex. Now, this is what's going on in terms of like the neurophysiology behind urination. So here's the first step right over here. You have urine accumulating within the bladder. It stretches out, right? So the stretch receptors now are going to start sending afferent signals to begin and initiate the urination reflex, the micturition reflex. So those first fibers are going to be sending afferent signals to the pelvic nerves. Those afferent signals are going to be associated with parasympathetic motor neurons, and then you're going to get stimulation of muscle contraction. So that's going to be your detrusor muscle. So make sure you know your detrusor muscle contraction is going to be all those smooth muscles around the bladder that now are going to start contracting, allowing for urination to take place. Other things that can happen once you start getting into the central nervous system. In the central nervous system, that's where you start getting more voluntary control of urination. The central nervous system, of course, is going to be associated with voluntary control of the external sphincter, right? So the external sphincter is going to allow for, to prevent incontinence, right? So you'll be able to make your way to the bathroom without causing any sort of accidents. So here's a summary of what could happen if something goes wrong with this whole process, especially with the neurological component. So if a person loses tone of any of these muscles, that can result in incontinence. This can also happen to women after delivering a child, right? So you might get weakness of the pelvic floor. If you get weakness of the pelvic floor muscles, sometimes that can result in incontinence. It's a very common phenomenon, especially for women who have had multiple children. But there's ways that you can strengthen those muscles again, right? You can do like Kegel exercises, things like that. Those can help to regain strength and control of those muscles that were weakened through childbirth. Other things that can happen: central nervous system damage, right? So strokes can cause this. Alzheimer's can cause this. Anything that's going to affect your brain can possibly affect the voluntary external sphincter, right? So you won't be able to actually control urination. Very, very common theme with stroke patients. Stroke patients often have to wear diapers. Okay, so that's going to be a very common thing for stroke patients. For guys, benign prostatic hyperplasia, BPH, very common condition, right? It's going to be enlargement of the prostate. When you have prostatic enlargement, that's going to impinge on the urethra. So it's going to be really hard for urine to properly pass through the urethra during micturition. Guys with BPH are going to complain of little urine production. They're also going to complain of increased urgency and frequency. They're going to want to use the restroom more because the bladder is inflated with urine, but they're not going to be able to pee as much. So they're going to go to use the bathroom. They're going to trickle a little bit of urine out and finish. Then they're a little bit later, they're going to have to urinate again. So you have increased frequency and urgency. So very annoying. I have a friend of mine who's older. He had to actually get a surgical procedure done to try to prevent that from happening. And now, instead of what he had before with like frequency and urgency, now he has incontinence. Now he has to wear diapers. So it's a tricky situation. So urology is it's a tough field because if you mess anything up here, it can cause incontinence, and it's not great. What's up? A bladder infection would be cystitis specifically. Urinary tract infection is mostly involving the urethra. And then once you go up past cystitis, past the bladder, then that would be pyelonephritis or glomerulonephritis. Okay? But they could all start with a UTI. The UTI can, if left untreated, could progress onto those other conditions, cystitis as well as glomerulonephritis. These are the different types of incontinence. I'm not going to test you guys on incontinence, but you guys will be tested on incontinence when you guys get into pathology, okay? But these are the different types of incontinence. We already talked about this one over here. As you know, that's the prostate right there. I know it's not noted. So this is a male urinary tract. So this is the prostate. If you have prostatic hyperplasia, benign prostatic hyperplasia, or even prostate cancer for that matter, you could impinge on the urethra, and that's going to result in urine like pooling in the bladder. So you're not going to be able to get the urine out. And so that's going to result in overflow incontinence. The bladder literally just starts overflowing. And so with these patients, they can't pee completely. They can't eliminate all the urine. There's always going to be a little bit of urine or quite a bit of urine left behind. So they're going to have increased urgency, increased frequency. Stress incontinence is going to be due to weakness of the pelvic floor. That could be due to like postpartum, like after delivering a child. That could weaken the pelvic floor, resulting in stress incontinence. Urge incontinence, that's going to be involuntary contractions of the bladder. And then neurogenic incontinence, that's like if you had a stroke, right? Or if you had Alzheimer's. You don't have the proper neurological control of the micturition reflex. So these are the different types of incontinence. You guys will be seeing that quite a bit when you guys get into your clinics. Any questions? That's it for urine, for urinary system. You guys want to do the quizzes questions? And then we'll finish up for the day? Awesome. So I just looked up what anxiolytics do. So it's a GABA drug, right? So anxiolytics like Valium, like Xanax, those types of drugs are going to operate on GABA receptors that cause like neurodepression. So what I saw is that the GABA receptors, if you use anxiolytics, that can like result in difficulties contracting the urinary bladder, so you can actually have urinary accumulation in the bladder, so that can result in incontinence and urinary retention. So that's kind of what's going on with benzodiazepines. Yeah, no sweat. I'm sure there's other stuff going on with that, but that's what I found on a nice quick Google search. All right, what's up? Foley catheter? Yeah, totally. Yeah, if you have like a person that has like BPH, benign prostatic hyperplasia, you could totally catheterize them. There's actually people that do that to themselves, right? If they can't like properly urinate, they'll actually self catheterize. And even though they're doing it themselves, and it seems like it's uncomfortable, it's way more relieving for them to actually be able to finally pee. So yeah, it's kind of weird, huh? To like be able to self catheterize. Yeah, I wouldn't personally want to do that to myself, but good. Most of you guys got that correct. Micturition. Filtration, where does that happen? Huh? Where? Yeah, at the glomerulus. Yep. Filtration at the renal corpuscle, glomerulus, Bowman's capsule, all that. That's where you see filtration. Mastication, chewing. Deglutition, swallowing. Good. Those are the wrong answers. Good. Most of you guys got this one correct, which is awesome. So reabsorption of sodium chloride ions. Now, when it comes to the nephron, where do you see reabsorption of water? The descending limb. The ascending limb is impermeable to water, but instead you're going to get the reabsorption of sodium chloride. So good job on that one, guys. Good. Most of you guys got that correct. The renal threshold and then the transport maximum. That's what the TM is. The transport maximum, that means like you're saturating all those carrier proteins, right? And then once you exceed the amount that your kidneys are able to actually reabsorb, then that's when you hit the renal threshold, and that's when you actually start finding those different solutes winding up within the urine. Bless you. Good. You good. Once you go beyond the renal threshold, that's what happens. You get substances winding up in the urine. Loss materials that your body wants to get. Not really. For instance, yeah, no. And then reabsorption of filtered substances. So yeah, you don't get reabsorption if you hit that renal threshold. That's when you find things winding up in the urine. It could be even like, things that you don't necessarily want to be reabsorbed anyway. So it's definitely D. I really hope somebody put in D. Nobody put down D, really? ACE, angiotensin converting enzyme. Where do you find ACE? Okay, let's go through that step. Let's go through that cascade. What gets released by the liver? Good. What gets released by the kidney? Renin. Okay. Then let's see. Angiotensin 1, when it gets to the lungs, that's where you get ACE, right? And so if you're using an ACE inhibitor like lisinopril, captopril, any of those drugs, it's going to be targeting the ACE enzyme in the lungs, okay? So, yeah, definitely go over that renin-angiotensin cascade. You guys need to know that. And we just went over that, so I hope all of you guys get 100% on this one. All right, good. Yes, lungs. Oh, sorry, liver. Lungs, it will be ACE. Okay, next. So BNP was named after porcine BNP. Porcine means pig. And so when it was first discovered, it was discovered in pigs. And so they discovered in pig brain. when in reality, it's mostly going to be associated with the ventricles, right? And so what does BNP and AMP do? They respond to like fluid volume, right? So blood volume. If it's a lot of blood volume, brain natriuretic peptide and atrial natriuretic peptide, what are they going to do? Are they going to reabsorb sodium or excrete sodium? Excrete sodium, right? So they excrete sodium, water follows solutes, so they can excrete more fluid, so they can reduce their fluid volume. Looks like most of you guys got this one correct. So just know filtration, glomerulus, reabsorption, proximal convoluted tubule, and secretion, distal convoluted tubule. Reabsorption and secretion are going to be happening in other areas too, but this is like by and large, right? This is going to be like where the majority of these things are taking place. So if the afferents are vasoconstricting, are you getting more blood to the glomerulus? No. What's that going to do to your GFR? Down. Good. If your afferents dilate, are you getting more blood to the glomerulus? Yes. What's going to happen to your GFR? Up. Good. If you downstream, you vasoconstrict the efferent, what's going to happen? Is blood going to stay longer or less time in the glomerulus? It's going to stay longer in the glomerulus. It's going to increase the pressure in the glomerulus. It's going to allow for more filtration. GFR goes up. Okay, so make sure you know what's going on with vasodilation and constriction at the arterioles. Very important. All right, just make sure you know where these are going to be taking place. Antidiuretic hormone, aquaporins, distal convoluted tubule, and collecting ducts. Okay, it's not going to be aquaporins are not associated with aldosterone. Aldosterone is just sodium. You're bringing in sodium, you're excreting potassium. Okay, so a little bit different process. I know it's getting towards the end. We have 2 more questions. If those of you need to leave, that's fine. If anyone who wants to stick around and finish the rest of the questions, can feel free to do so. It's similar to ADH, aka vasopressin. You're going to see aldosterone also having the bulk of its effect at the distal convoluted tubule and those collecting ducts. But the big thing that's happening here, you're having reabsorption of sodium, excretion of potassium. So prolonged exposure to aldosterone, you would be hypernatremic, and then you'd be hypokalemic as a consequence. Just 2 more. All right, so that's a mixed bag. So one thing to keep in mind about smooth muscles, right? So like the detrusor muscles, for example, that are within the bladder, that's parasympathetic, right? So it's going to be parasympathetic activation. So stretch receptors, it starts, right? The bladder stretches out, and all of a sudden now you have a parasympathetic cascade taking place where you have different innervations of the smooth muscle to allow for contraction of the bladder. Then the skeletal muscle is going to be more voluntary, right? That's going to be the external sphincter. But know that stretch receptors are what start micturition process, and it's going to be mostly parasympathetic in terms of its activation and how it's mediated. All right, last one before the rest of you guys leave. So. Cool. Overflow incontinence. Urge incontinence, think about like a pregnant woman that just had her child, right? It caused like weakness to the pelvic floor after childbirth. That would be urge incontinence. That would be stress incontinence. Urge incontinence would be like the bladder is contracting when it shouldn't be contracting. So awesome, guys. Have a great weekend, and I'll see you all on Tuesday. The quizzes, it should be in the updated lecture slides at the very end. Is it not? Huh? It's not on there? It is on there. So go check and see. If you need to reach out to me, send me an email. I can send you the link.